Morning, everyone, and morning to those online. Welcome to our first academic meeting of the year. It's nice to see such a full room. We are sponsored this morning by Asino. I'm going to give Zubair a chance to talk after the meeting, so the room's nice and full, Zubair, and you have more people to talk to. But we're starting off this year with pulmonology, and our speaker this week is well known to most of us, Dr. Vivendra Naidoo, who has asked me specifically not to tell you his full CV and bio because it'll take up the duration of the meeting. He's very illustrious. But no, in all seriousness, Viv is a pulmonologist here at Charlotte and at Wits, and he has a keen interest in medical education as well as interventional and diagnostic pulmonology. And his claim to fame, which he doesn't want me to tell you, but he, together with the team, established the interventional pulmonology unit here at Charlotte. And they are doing all sorts of amazing things like performing cryo lung biopsies to assist in the diagnosis of interstitial lung disease, as well as all sorts of other amazing things, stealing work from the cardiothoracic surgeons. So without further ado, I'm going to hand you over to Viv, who is going to talk to us about whether size matters.
All right, morning everyone, and thank you for attending today. So we'll start off this year's academic meetings with a bang, no pun intended. And today we'll discuss the size matters. Just to put everyone at ease, this is a pulmonology talk, and I'll be discussing pneumothoraces, particularly spontaneous pneumothoraces. And just to start off with, we're going to look at the definition. So spontaneous pneumothoraces is basically in the pleural space occurring in a non-traumatic context. And very important because I know, and not to call you guys out, but our students, our registrars, like when we ask on the ward round, give me causes of pneumothoraces, trauma always comes in, and obviously we aren't dealing with trauma. So this particularly defines to a non-traumatic context. Primary spontaneous pneumothoraces occur in patients without any obvious underlying lung condition. That's on initial diagnosis. You may find further down the line that there is something wrong once you do further imaging, where secondary spontaneous pneumothoraces are those in patients with known underlying lung disease, typically things like COPD, pneumocystis jirovecii, or post-TB structural lung disease. So this is a very nice table from up to date, highlighting some of the non-traumatic, again, causes of spontaneous pneumothoraces. But I think in our settings, there's a few I'd like to highlight. Cigarette smoking. So cigarette smoking increases the risk of your initial event for spontaneous pneumothorax, as well as subsequent recurrence after resolution. COPD obviously as a consequence of cigarette smoking. And not forgetting our setting, biomass exposure in a lot of our patients due to kind of our historic, economic disadvantages a lot of patients had. A lot of patients using paraffin, coal, and firewood in their, growing up. So COPD due to biomass still remains an important component. Infection, obviously, unfortunately, very common in our setting, pneumocystis and TB in the setting of our HIV pandemic, as well as necrotizing pneumonias in those with bacterial pneumonias. And then malignancies, unfortunately, primary lung cancer and metastatic disease, especially those patients with osteosarcomas, very aggressive, like to metastasize to the lung. And typically, the primary presentation will be that of a pneumothorax or a hemothorax. Then if we look specifically at causes of cystic lung diseases, because of those patients with structural lung diseases are probably the most common ones which are going to cause cystic lung disease. Again, quite an extensive list. This is from up to date, as you can see, so you're welcome to go reference it again. But don't want to spend too much time on this because it's not really the focus of the talk. So if someone does present with a pneumothorax, the first thing we want to know is what is the best way to diagnose it? So the first question we ask ourselves is CT better than chest X-ray to diagnose and determine the size of a primary spontaneous pneumo, or if it's a differential diagnosis? Simple and straightforward answer is yes. One, it will better assess the size as well as if there's any underlying lung disease. However, CT is not really available in all settings. It's costly, accessibility is an issue as well as radiation exposure. So X-ray still remains first line in terms of ease of access, but CT is definitely better. So chest ultrasonography is quite something that's becoming quite popular now. At our last pulmonology CME, we had a whole workshop on it. We're also hoping to have one of the physicians update coming up. And we do know that it has better sensitivity for the diagnosis of even small pneumothoraces. But is it better in terms of patients initially presenting to the ED? So unfortunately, the literature doesn't really go for or against it. There's not enough to advocate for or against it. And it also really depends on the ability, or rather the experience of the operator, because it is a learning curve. It's not very steep, but you do still need to be able to do it. And I think in this day and age, chest X-ray still remains a valuable tool in diagnosing as well as looking at the size of a pneumothorax. But then ultrasound for looking up or following of successful resolution and drainage of the pneumothorax. So ultrasound does perform better than chest X-ray, provided that the operators are at a similar level. So again, this becomes a bit of a difficult concept because not everyone is necessarily skilled or at the same level of expertise in terms of chest ultrasound. It's still something that's taking off, I think, both in state and public, state and private rather. It's not being readily done by a lot of physicians. So chest ultrasound is better to look for resolution of your pneumothorax, but provided that the operator is at the same level or it's the same operator performing the subsequent ultrasounds. So when you look at a management of pneumothorax, there's three specific areas we're going to look at. The acute management of the patient, which I think is what most of us need to deal with. Patients have persistent air leaks, so that means there's no resolution of the pneumothorax after about, varies within the literature, but somewhere between 5 to 14 days. Especially those are not fit for surgery. If your patient does present with a pneumothorax, what is the best way to prevent recurrence? So acute management can be divided into four aspects, which I'll go through in a bit more detail. We look at conservative management, needle aspiration versus chest drain. And chest drain is commonly what I think, are most averse to and most commonly used. Ambulatory or outpatient management, as well as which patients should be advocated for early surgical management. So when we look at conservative management, this is where the question comes in. Does size really matter? So the answer just depends who you speak to, because different bodies will have different, answers on whether or not this is important. But before we get there, how do we actually measure the size of a pneumothorax? So this diagram here looks at how to measure the pneumothorax depending on the size in terms of percentage. But when we're looking for size in terms of whether or not to intervene, we look more commonly at figure mark B here, which is the interpleural distance from the chest wall, kind of at the level of the hilar area. And the cutter point we normally use is about 2 centimeters, determining whether or not it's something we need to worry about or something we don't need to worry about. So if we look at the ERS guidelines in terms of who we can take conservative management, they don't really advocate much or don't really worry much in terms of the size. It rather depends on your patient's symptoms, whether they're clinically and radiologically stable. So clinical aspects of stability I'll go through in a subsequent slide. Radiologically stable just means that X-rays repeated every 4 to 6 hours are not showing any increase in the size of pneumothorax. And importantly, are patients able to come to early clinical follow-up? This is a challenge a bit in our setting because, patients in terms of transport and able to get back to the hospital is not always possible. But if your patient is able to come back, every 24 hours for assessment for up to 72 hours, that can be helpful. If you look at the French group who decided to do a kind of breakaway from the ERS, despite the fact that they are part of Europe, they advocate for size. So if they use a cutoff size of less than 2 centimeters, so if it's more than 2 centimeters, they don't opt for conservative management, but less than 2 centimeters, they feel this patient can be managed conservatively. But again, the important thing being outpatient management. And they advocate that the same physician follow up the patient as an outpatient because they know the clinical and radiological kind of benchmark or baseline of that patient. BTS only really uses size whether or not it's safe to intervene. So if it's less than 2 centimeters, they feel even if the patient may be asymptomatic or symptomatic rather, it may not be safe to intervene, especially in terms of chest drain because of the risk of lung injury. More than 2 centimeters, if the patient's stable, they still advocate that you can opt for conservative management, but if the patient is symptomatic, you can then intervene. The important thing to note here, they do advocate a lot or mention a lot about outpatient management, but conservative management can still be done as an inpatient. If your patient is unable to come back to the hospital every day for serial x-rays, you can admit them and keep them in the ward. Yes, it is unfortunately taking up a bed, but those patients can wait there and you can do your x-rays every 24 hours. And then subsequently, if they find after about 2 to 3 days, then discharge. So conservative management doesn't always mean outpatient management. It just means not sticking anything into the chest. So the definition of stability, so this is what is defined according to UpToDate, and it's from two major groups using the British group as well as the American College of Chest Physicians. You'll see I don't talk much about any American guidelines because their last ones were updated in 2011 for some odd reason, but a lot of the other guidelines do draw on this. But anyway, obviously your patient needs to be hemodynamically and respiratory stable, have adequate oxygen saturation within 90%, as well as able ability to walk freely. So they normally say if your patient can walk around the emergency department freely without any worsening of the symptoms, then they're considered clinically stable. If we then do decide to intervene in our patients, we have two aspects that we can use. We can either do needle aspiration or insert a chest drain or IC drain, as we more commonly know it as. We normally always or typically advocate for IC drain. I think not advocate, but I think in our practice, most of us have put in an IC drain. That's mainly because it's all that has been available to us. And also, needle aspiration can be quite time consuming, sitting there with a 50 ml needle and trying to draw 2 liters of air can take quite a while. So most of us normally default to a chest drain, but this is not always necessarily the best choice. And we can look at all of these kind of guidelines from the 3 major groups I've been looking at. Most of them at least the ERS advocates for needle aspiration over chest drainage, but the French and the British group don't find that there's much inferiority, shall I say, needle aspiration versus chest drain. Needle aspiration, obviously, much less complications, it's much more comfortable for the patient. Chest drain management in patients, both in state and private, is not its best. It's uncomfortable with the patient, it requires a lot more analgesia, and a lot more complications. So needle aspiration will always be advocated for if your patient can tolerate it and if it works. The only problem with needle aspiration, as shown in this last point here, is that a big study that was recently done, 2023, showed that unfortunately these patients have a higher risk of failure. So that means there's a higher resolution of either their pneumothorax not resolving completely or recurrence of the pneumothorax quite soon after. And this is the paper that shows that. You can see the conclusion. Needle aspiration has a higher failure rate than chest tube drainage. So that means that they then subsequently did either need a chest tube drain or more definitive management procedure, but is better tolerated with fewer adverse events for obvious reasons. Ambulatory management. So this means we do something, we insert something into the chest, but we let our patients go home. And the main thing that we use in this setting is a Heimlich or one-way valve, which has an inbuilt or trash drainage device to it. Some centers do advocate for a mini chest drain, not the most practical thing for patients. It can be a bit difficult for them to manage at home, but still something that can be used. But we can see mainly we use a Heimlich valve. The French group did particularly say that, these patients, again, need to make sure they can come for regular follow-ups every 24 to 48 hours. So almost a case of, if you're going to insert something, might as well rather just admit the patient. So how does a Heimlich valve work? So it's very easy to insert, very similar to inserting a CVP. There's a introducer needle that you insert into the chest. So you drop a bit of saline into the needle, into the syringe. Insert your needle, aspirate till you get air out, and then the actual Heimlich valve, which is this thing here, is on the needle. You just slide it in through into the pleural space and attach your Heimlich valve. So very simple, very comfortable for the patient. And like I said, they can mobilize very easily with this and even go home with it. And it works simply by preventing air from flowing in. So if air flows this way, which will be back towards the chest wall, the sleeve closes, preventing backflow of air. And obviously when air is flowing out, the sleeve opens and allows the air to escape. So very simple, very easy to put in, much more comfortable for the patient. We typically use these in patients who may have post-procedural pneumothorax. So if you're doing a transthoracic biopsy or transbronchial biopsy and causing pneumothorax, these are very useful. The only place where these can't be used is the patient has a concomitant pleural effusion, right? Then these are contraindicated because the fluid then ends up blocking up the valve and it's not as effective. So the next aspect should be surgical management. Obviously, as far as possible, we try to prevent getting here because it then means your patient going to theatre. And like Jarrod said, we're trying to take away work from the cardiothoracic surgeons. So we ideally don't want to get here, but there are certain situations where patients will need it. The British guidelines and the ERS speak primarily about primary recurrence prevention. So I will allude to this a little bit later, also discuss it. But in patients with high-risk occupations, such as scuba divers, pilots, those working at high altitudes, and wind instrument players, their risk of recurrent pneumothoraces are high. So even after their first episode of a primary spontaneous pneumothorax, you may want to still send them into surgery just to get definitive management. Other indications where you should go for theatre straight away includes this list here. Just to go through a few of them, if there's a associated hemothorax, because there may be some underlying disease there. If you have another pneumothorax on the same side, or you have one on the other side, bilateral spontaneous pneumothoraces would be very unfortunate. Severity is not something we commonly use. If you can get away with intercostal drain, we may just say, we'll wait till you have your next one, but this is recommended by some of the guidelines. And then interestingly, also during pregnancy, if your patient has a pneumothorax, they should go for definitive treatment. Main reason being there, obviously, during delivery, when bearing down during delivery with the Valsalva, there is then an increased risk of recurrence of the pneumothorax. What about patients with persistent air leaks? So I alluded to it a bit earlier. So the definition really varies in the literature, anywhere between 2 and 14 days, which is a massive range. I mean, going for theatre after 2 days versus waiting 14 days, and all the subsequent days in between where all complications can develop is a bit difficult, and the guidelines aren't really, can give a lot of guidance on that. But often arbitrarily, we use about 5 days where we would consider someone having a persistent air leak. And in these patients, there's three kind of avenues that we can explore. The first two don't necessarily need any specialist or subspecialist intervention from a pulmonologist. This is autologous blood patch and suction. But endobronchial therapy is obviously where we may step in. But all honesty, it's not done a lot in the South African setting. And even overseas, if we look at it, it's mainly being done in research settings. So autologous blood patch is basically, as it describes, it's taking the patient's blood out and then inserting it back into the intercostal drain, normally at a dosage of 1 to 2 moles per kilo. It can either go really well, or afterwards it can look like the patient underwent thoracic surgery, depending on how much blood is out. It is difficult, because if you've got, for instance, a 50-kilogram patient, that's 100 moles of blood that you're trying to aspirate. You need a good line. Some people advocate for inserting a femoral CVP. That can be quite considered a bit of overkill just through a blood patch. So normally we try for a nice large bore cannula in the axilla, draw out your fluid or draw out your blood as however much you need, insert it back into the chest drain, and then clamp it afterwards for about 4 hours and repeat the chest x-ray thereafter. It's the one guideline or it's the one intervention that's really advocated for patients in secondary spontaneous pneumothorax. I think my oncology colleagues sitting here will know the challenge that we have with these patients. There's one patient in the ward, in fact, we tried, unfortunately failed. So it's not necessarily a fail-safe, but it can be considered in patients with secondary spontaneous pneumothorax. And the reason why the ERS doesn't advocate for these in patients with primary spontaneous pneumothorax is a feeling that these patients with primary spontaneous pneumothorax should be fit enough for surgery. I feel that's a bit of a weak recommendation to say don't use it in these patients. I mean, you're not risking all your patients being fit for surgery, but they strongly recommend it in patients with secondary spontaneous pneumothorax because these patients are normally frail and due to the underlying respiratory pathology may not necessarily be fit enough for anesthetic and for thoracic surgery. It does obviously lead to a quicker resolution of this pneumothorax and therefore a shorter length of stay. Suction. So again, not much advocation from the ERS and the BTS group. The French group does advocate for it if expansion is not achieved, particularly they say after about 3 days. We normally use it as a bit of a Hail Mary and hope that it may help, before we need to involve the surgeons. It does help, sometimes does not help, but that's why there's no real evidence for or against it. How do we actually do the suction? So the outsounding aegis, I think the older people in the room will know this machine. This is the Gomco machine which we used to use. Very difficult to use. You need to know how to use it, how to calibrate it, you need to know how to troubleshoot it, you need to know where to find it. And the patient basically, once this was connected, was kind of bedridden, all right? It's very difficult for them to come off and then disconnect it. Where are we sitting in 2026? Well, again, we can be proud of the medical innovations in South Africa. We have the Synapti drain, which is a South African invention. Much more simple, no fancy machines needed. You simply connect this to the wall suction, adjust the suction based on the dial here, and you let your patient go. Patient can easily disconnect and just needs to reconnect this suction tube to their drain. Much simpler, allows for much better care. And patients, before, I remember we used to have to accept patients for suction to Dara or Helen Joseph or Charlotte. Now we can just tell the patient, the hospitals, the district hospitals, do you have a Synapti drain connected to the wall suction, and hope and pray. Endobronchial therapies, so a little bit more, I guess, in my line of work and a bit more exciting from my side, but again, not something that's routinely being done, but at least something of interest. So options we have was that of endobronchial valves. So these work similarly to the Heimlich valve. Basically, they don't allow air to flow into the affected segment where we assume the leak is coming from, but will allow air to flow out, thereby reducing the leak from that particular segment. Endobronchial autologous blood pressure with thrombin patch. So this was only done by one group in Japan, but certainly very interesting and a very novel concept of rather than putting the blood into the chest cavity, inserted it directly into the affected segment endobronchially. ERS doesn't really recommend it for primary or spontaneous pneumothorax just because there isn't much evidence, as highlighted with the BTS group, which is very limited evidence. So just out of, for interest's sake, so this is just a few images from the Japanese study. So Caption A shows, so this is a balloon, rather a metal detector that is used to determine where the leak is coming from. So this is used to see where, if the segment you're involved is where the air leak is coming from. And then this is then the insertion of the autologous blood patch, much smaller volumes, only about 3 mils needed. So beneficial from that regard, in that it's not as difficult then to obtain your amount of blood required. Column C and D show the silicone spigot. So this is basically tied in and then inserted and used to block up, again, the affected bronchus in the affected segment. This is basically just the results from that particular study. So you can see, in terms of successful resolution, very similar between the two groups. However, duration of air leak stopping was a bit quicker in the spigot group, and hospital stay was shorter also in those who had the silicone spigot. So while certainly an interesting and novel therapy, autologous blood patch not necessarily something that is going to take off necessarily anytime soon, and probably more research is needed on that. Sorry. Then once we've hopefully successfully treated the initial event, how do we prevent recurrence? And there's two main avenues that we use here, being chemical pleurodesis, and then the more aggressive or more interventional thoracic surgery. So chemical pleurodesis in ideal setting should be done with medical grade talc. Again, very difficult to procure, and there have been a lot of problems with the quality of the talc that has come through, a lot of allergic reactions and adverse events in recent years. So it is difficult to obtain talc. So in our setting, we sometimes use povidone, and in certain settings, sometimes in malignancy, we use bleomycin also. In terms of patients with primary spontaneous pneumothoraces versus chest drain, not really any difference in the length of stay. Chemical pleurodesis, again, can, versus just waiting for it to, autopleurodesis, for the lung to fully re-expand and autopleurodesis. Again, it's a bit of a laborious procedure, so you might, and patients do need analgesia, so you might kind of say, we'll just wait for the lung to re-expand fully and autopleurodesis. However, there is a lower recurrence rate, so that may then be the benefit that you're looking forward. As mentioned, though, more need for opioid pain relief, because you are causing a chemical irritation with the pleural space, so obviously it is going to be painful. The French group particularly looked at the recurrence rate when you look at mechanical pleurodesis. So mechanical pleurodesis is basically where thoracic surgeons go in and actually scrape the pleura to incite an inflammatory event, and obviously all the cytokines and inflammatory mediators will then cause scarring and basically sticking of the parietal and visceral pleura to each other. When combined with these, there was a much lower recurrence rate. If we combined chemical pleurodesis with mechanical pleurodesis, even a further reduction by further 63%. So still a very good option, and still does have a very good role, especially for patients in secondary spontaneous pneumothoraces. If we look particularly at thoracic surgery, when compared to, chest drain alone, obviously a shorter length of stay because you're intervening and fixing the problem sooner, lower recurrence rate because you get more definitive therapy. However, again, because you're taking in your patient to the theater, they then require post-op care in ICU, chest surgery, obviously causing pain. And as Prof. Richards will always tell you, how successfully you do after surgery depends on your ability to cough. If you just had major thoracic surgery, you're not going to be very willing to cough, higher rates of pneumonia, and more persistent air leak. Interestingly, though, no mortality benefit, and I'm sure most patients, if you tell them that, would probably opt more not to go for surgery. When compared with chemical pleurodesis, not much evidence in both primary and secondary spontaneous pneumothoraces. And we can see that the French group says you should combine all three together and you get a much better outcome. How is the thoracic surgery done? Just as a note, more for interest sake. So either they do a pyorectomy in the affected segment and plus minus taking out a bit of parenchyma, normally just about less than 2 centimeters of the affected area where they feel. So in your patients with your primary spontaneous pneumothorax, you just have apical blebs. They'll do an apical pyorectomy and maybe take out a bit of the parenchyma depending on how deep the blebs go. All right, so this is all not fake news. There's a nice summary table just to show you kind of what we've discussed. So the gold standard will always be ICD for the intervention or for the management of a pneumothorax. And these just show how the different modalities that we've discussed compared to the ICD drains. And if we again look at, this is a nice, if you need to discuss options with your patient, kind of what is especially I think, what is the risk of recurrence and often a further procedures needed. This can be a good guide in terms of deciding which intervention you're going to choose. As we obviously know, thoracic surgery is our lowest risk of needing a further procedure because you're dealing with definitively from the onset. But you can see, unfortunately, our more conservative management procedures may require something more definitive or another procedure in a later event. So the next three slides are going to be the summary tables or summary flow diagrams from the three guidelines that we discussed, which I think are very useful. But the one I would really recommend is this one here, which is from the British guidelines. And they released a nice paper, I think about 2 or 3 years ago, where they discussed pleural disease, both pneumothoraces and effusions. It's a lovely short 10-page guideline with very nice flow diagrams for all of these things. And I think this is probably the one that most of the pulmonologists in South Africa will follow. This is the ERS guideline, perhaps a bit more simple, but they really advocate a lot earlier for more definitive management. You see insert chest strain there, quite early consideration of chest strain in vets. And then the French group, a little bit more complicated and I think a bit more extensive. So again, not one that we commonly use, but is something that you could also look at. So how should we manage our patients after the initial event? So follow-up really, and both these two together, both follow-up indications for CT scan will really be dependent on what is your suspicion for a underlying lung condition in this patient. So if you feel that it's a pure primary spontaneous pneumothorax and the patient really doesn't have any underlying disease, that good resolution post whatever intervention you choose and good resolution maybe about 2 weeks to a month later, those patients don't necessarily need follow-up or CT scan thereafter. But patients who don't show good resolution, have persistent air leaks, or where there's a strong suspicion for underlying connective or underlying lung disease rather, a CT scan would then be indicated in these patients. Then lastly, just in terms of precautions, so smoking I chatted about earlier, increases your risk for your initial event as well as recurrent events. So smoking cessation obviously advocated in the setting of pneumothorax, and this generally in life, obviously it's good to not smoke. Flying varies between the different guidelines. So we say there should be full resolution, radiological resolution of the pneumothorax before considering flying. The British guidelines recommend at least 7 days, whereas the French guidelines say 14 days. So generally, anywhere between 7 to 14 days after this clinical resolution of the pneumothorax, patients are safe to fly. Skydiving and free fall. So in these patients, because they are going to be at high altitudes, we do recommend that these activities only be commenced if there's been definitive management done. So that either is chemical or mechanical fluorodesis or a thoracic surgery done. Scuba diving, especially with tanks, is not advocated for any patients. So we don't recommend that patients go scuba diving, even if definitive management is undertaken. Physical activity and wind instruments, no limitation on that. Once there's resolution of the pneumothorax, it is then recommended that patients can resume these activities. We don't want to necessarily say, don't go exercise. And definitely if patients are using wind instruments as a vocation, we say go ahead and carry on as soon as there's resolution of the pneumothorax. Then again, depending on what specific, I alluded a bit to which patients need workup. So this is basically, a summary table of what specific things to look for if your patient then needs further workup or management. And you can see primary spontaneous pneumothorax, really not much. You can manage them conservatively, and there's a low risk of recurrence. Whereas in the secondary spontaneous group, a bit more intervention needed, a bit more workup needed. All right, and that concludes the talk. Any questions?